Thank you all so much for joining today's Public Health Discovery Seminar Series. My name is Cassietta Trewick. I go by Cassie. I'm one of the admission counselors here at Celia Scott Weatherhead School of Public Health and Tropical Medicine at Tulane University. And today I have the honor of introducing Dr. Patricia Kissinger, who is a professor and associate dean for Faculty Affairs and Development here at the School of Public Health and Tropical Medicine, and she is a part of the Department of Epidemiology. And so today I'm going to allow Dr. Kissinger to present on the state of HIV, STIs in the United States. So, Dr. Kissinger, take it away.
Great. Can everybody see my screen?
Yes.
Cassie, you can?
Yes, ma'am.
Okay, perfect. So welcome, everyone. Good afternoon. My name, again, is Dr. Patty Kissinger. I'm a professor of infectious disease, epidemiology, specifically focusing in on sexually transmitted infections and HIV, which is, of course, the sexually transmitted infection. Today, I'm going to talk to you today about a specific program that deals with one kind of STI. This is our poster for the Check It program. The Check It program is a community-based chlamydia and gonorrhea screening program for young African-American men. And I'm going to explain to you why we landed on that group and why we're doing it in just a second. So first of all, I do want to say STIs, or sexually transmitted infections, are common and very costly. So we know that in the United States at any given time, there are about 1 out of 5 people have some kind of STI. So that's quite dramatic. A lot of that is incurable STIs, such as human papillomavirus and herpes simplex virus, but a lot of it is curable. And I'm going to talk today to you about one of the curable ones. There are about 26 million new cases. In 2018, there were, and it's about the same every year. Half of these infections occur in young people, people under at the age of 25, sexually active people under 25. So we know that it really disproportionately affects young people. It costs about $16 billion a year for these STIs. So not only are there a lot of people that have them, but they cost a lot of money. So what is chlamydia? Chlamydia trachomatis is a sexually transmitted infection. It's the most commonly reported sexually transmitted infection in the United States. So some particularly infectious diseases are reportable so that we can surveil them and monitor them. Worldwide, there are about 130 million cases of chlamydia trachomatis. In the United States alone, there are about 1.6 million cases. So highly, highly common. Most people who are infected don't have any symptoms, which is really weird. So you might say, well, who cares? If you don't have any symptoms, why would we care about this STI? Well, this STI, even if you don't have symptoms, is causing a low-level inflammatory state. And anytime you have inflammation, you can cause people to be at higher risk for HIV and a number of other unhealthy outcomes. You can get chlamydia in the genital tract, so in the vagina or the penis, but you can also get it in your mouth and you can get it in your anus. So there are extragenital spots where this infection can occur. Chlamydia is a big cause of infertility, ectopic pregnancy, and chronic pelvic pain, as well as lots of morbidity or sicknesses in infants born to mothers who have chlamydia. And also, as I mentioned before, it can amplify both transmission and acquisition of HIV, which is very costly. So in the female genital tract, this is what chlamydia looks like. And this is, of course, a cartoon of it, so it maybe that dramatic, maybe bilateral, but this is a situation to show you what a normal fallopian tube looks like, and this is what a highly inflamed fallopian tube that would be considered probably pelvic inflammatory disease. So what happens is the sperm can get up the cervix into the uterus, and the egg can get through, just so it can only go a certain pouch to the fallopian tube. Conception occurs and it implants in the tube rather than the uterus. A baby can't survive in the tube, so that would be a spontaneous abortion. It would be a very urgent medical event if it happened. Many, many women who have chlamydia also get a thing called endometritis, which is an infection or inflammation of the inside lining of the uterus. In men, we used to think that chlamydia didn't matter at all in men, but we now know that it does cause epididymitis, which is this little gland around the testicles and the outside part of the genitalia in men. It can cause that. It can cause a urethritis, and there is some indication that it can cause reduced sperm motility and morphology abnormalities. But most importantly, the men are the reservoir for the women. So if you get all the women screened and all the women treated, but you don't ever screen or treat the men in a cisgen heterosexual circumstance, those women are just going to get reinfected. So we really need to consider the men. There's other outcomes. You can get infections in the eye from chlamydia trachomatis. You can also have like arthritic type of things. So there's lots of sequelae or unhappy outcomes that can happen with chlamydia trachomatis. And as I mentioned before, so much of chlamydia is in teenagers. And if young people are at highest risk, they constitute only about a quarter of the population in the United States, but they comprise half of all the STIs. So young people are at much higher risk. And this is a graph that comes from data from CDC. And you can see that it abruptly, it really goes down. The prevalence or the number of cases that are detected really after 24 goes down quite dramatically, which is a little bit artifact because we only screen in women and we stop screening generally after 24. So you can see, though, that we do have a great deal of infection in both men and women. Even though women, we screen, CDC recommends screening, men, they do not. So they just screen whenever a person has symptoms there. But if you look at a population-based study, if you can see where my cursor is going, men and women have about the same rate. So really, it does indicate that we really should be screening men, but CDC has yet to say that. Black men are 7 times more likely than Caucasian and Asian men to have chlamydia. So it's highly disproportionate in African American youth. So this is why we really need to, and people might ask why. You could have lots of different answers. Could come down to just, you could say as high as racism, could be a root cause, all the way down to just lesser access to care and poverty and a number of other things. Why in New Orleans? Well, we know that in Louisiana in 2022, Louisiana had the highest rate of chlamydia in the country. We beat out Alaska. Alaska used to have the highest, but we now are back to having the highest, which is not really something that we're proud of. In metropolitan New Orleans, we're about the 9th highest of metropolitan areas to have. So we have very high rates of chlamydia in our area. So CDC, or Centers for Disease Control and Prevention, and a number of the accrediting agencies or professional agencies agree with the screening recommendations that all sexually active women under the age of 25 should be screened annually for chlamydia. However, for men, they only recommend that screening of men in really high prevalence settings, such as adolescent clinics, correctional facilities, STI specialty clinics. And of course, men who have sex with men should be screened because of very, very high prevalence in that group. But in the cisgen, when I say cisgen, I mean people that are having sex with, that express their gender the same as what they were assigned at birth. So cisgen men who are heterosexual, meaning that they at some point had sex with a person with a vagina, that person, they do not recommend just general screening of those people. So I was a part of this consultation that was done way back in 2006. And this is when they were trying to determine, should we have a recommendation to screen men? And the consultation, I was probably the lone dissenter. They said, nope, we're not going to do it because we have limited resources and we don't know where high prevalence men, heterosexual men are. And we don't know if it's going to have any impact on women because they mostly care about the impact on women because they do have the more severe sequelae, particularly the sequelae that involve unborn children. So this consultation, and so this was the catalyst for me to engage on Check It. So I did a bunch of precursor and pilot work, and then eventually, we've been screening women under these recommendations since 1990. And as you can see, it's really not making much of an impact. The rates in both men and women continue to go up. This differential between men and women is screening artifact. But you can see that it's going up, even though we continue to screen. It's not really abating the constant continual increase in the rate of chlamydia. So the study has 2 particular questions. First is feasibility. Can we screen young African-American men for chlamydia in a community-based setting? Instead of making them come into a clinic, can we go out and find them in a seek, test, and treat manner? And also impact, will it have any effect on the rates in women? So that's a little tricky to do an intervention in one group and then assess the outcome in another group. So I'm going to tell you how we did that. Why don't Black men, so why don't we just tell them all to go to the STD clinic? Well, they don't go into the clinic. A lot of young men of all races, but particularly African Americans, if they don't have symptoms, there's nothing to prompt them to go. They might be mistrustful of the setting. Many STI clinics have very rigid hours, and they don't allow you to bring children there. And so there's a lot of reasons why that produce barriers for people to get appropriate sexual health care. There's fear of knowing the results, fear of having to take medicine, fear of having to tell your partner. There's also limited access to healthcare, which I just described. Sometimes young people don't have copays, they don't have transportation, they don't have insurance. The insurance is on their parents. They may be too embarrassed or to ask to go to the clinic. They may be afraid of stigma, certainly confidentiality. And then there's also a little bit of denial and magical thinking, like if I just don't deal with it, it'll go away. Well, that doesn't work very often. So we have to go out and find people. We also have very poor sex education, particularly in the Delta South of the United States. We have very haphazard sex education. So people don't even know about this infection oftentimes. So as I mentioned, those are our research questions. Should we screen men? How do we do it? How do we get them and their partners treated after we detect a particular infection? So we had a really robust staff, many students from the School of Public Health, some staff members from the School of Public Health. We also had, medical students, all sorts of people we enjoyed working with a large group of varied people. We had a medical doctor who was our prescribing doctor. That was Dr. David Martin. Myself as an epidemiologist, Dr. Elisa Letter, who was our behavioral scientist, Dr. Charles Stecker, who's our economist who did the cost studies, and then Dr. Mac Hyman, who is our mathematician and did mathematical modeling. So you'll see in the evaluation, we took a very multi-modal approach to evaluating it. So it's a bundled intervention, and what it is, it's a compilation of many evidence-based interventions. So these are all interventions that have been proven to work in other settings, and we bundled them all together in this toolbox. So first of all, we wanted to seek, test, treat. We wanted to go into the community to find them. So we established partnerships with many people in the community. We also we wanted to use the power of the peer. So we asked peers, people who are in the community, to recruit other people in the community for us. And at first it wasn't incentivized, and then we did end up giving them an incentive. We also reminded people to get rescreened. So anybody who was positive for chlamydia and or gonorrhea needed to get rescreened at 3 months. That's per the protocol of CDC and others. We also wanted to make sure that the index patient, the person who was detected with the infection, got treated right away, and their sex partners got treated right away. And we also had a website that provided some education. It had a little AI component. You could ask questions and it would answer the questions. If the AI didn't know the answer, then it popped up a phone number for you to call. And I'm a nurse, and some other people on my staff were medically involved and could answer the questions. And we also gave a modest monetary incentive. So for getting screened, you had to do a little survey. You could either get a $30 gift certificate, or at first we were doing you could get a free haircut. So the barbers would get the $30, the guy would get a haircut, everybody would be happy, and we'd have somebody in our study. So that was really a good initiative. It worked for a good long time. It didn't work the entire time. So what we wanted to do is make it as easy as possible for these young people to get tested and treated. So all they had to do is give a urine specimen. They just went into the restroom, got a urine specimen. We shipped it off to get it tested using nucleic acid amplification testing. If they were positive, we set them up with one of our partnering Walgreens, and they could go in and get the medication for free. The study supported paid for the medication. And then they just had to take 2 pills. If it was chlamydia, they took 2 pills of azithromycin. If it was gonorrhea, they took a couple of pills of cefixime, And that was it. And then, but you also had their sexual partners. So we also offered medication for their sexual partners that they could provide to their sexual partners. It's a technique called expedited partner treatment, and it's legal in all states of the union. Okay, so yeah, you really have to think about how do you get those sex partners treated. There can be consternation or not. So usually the index patient knew who they could give it to and who they couldn't give it to. They wouldn't give it to somebody that they thought might perpetrate violence on them. And we had no episodes of violence except one woman who said we had not in the study. We had no episodes of violence. Okay, so we had a website, and this is our logo. And if anybody know who this is, you can put it in the chat. Who do you think that is? Okay, well, I'll just tell you who it is. That's Kendrick Lamar. So we did a series of focus groups, and we figured out who exactly we would want to be as our poster child. So Kendrick Lamar was chosen, and we adapted it enough that our intellectual property people would agree that this is, it's different enough that we didn't have to have royalties, or we actually copyrighted this. And so we had a website that had all sorts of information. The group that helped us develop this website was a local community-based organization called Youth Empowerment Program, or YEP. They were fantastic, and they were helping us with the marketing, and they were helping us with the website. And so they were really great. And they come from the same community of the people that we were testing. We did a lot of marketing. I think social media was our best bet. We did a lot of engagements, and we did a lot of advertising for the study itself. We also did a series of posters. We had palm cards that we could pass out to people. And sometimes people liked the palm cards because they could engage in discussion with the person. We had peer referral, as I mentioned, and then lots and lots of community engagement. Here's one where we did an open mic night, where we invited young people to come and do spoken word or just, sing. And we got people there. If they wanted to be tested, they could be tested. We also, on our social media, we played a lot of games. We did like condom demonstrations. Here's a nope or dope. So we would ask provocative questions and then ask them, did they think that's good or bad? Nope or dope. And so then we would post the results, and people really liked that kind of engagement. I showed this picture because he was one of our main barbers. And so we put a crown on him because he recruited a whole bunch of people for us. So we had a very robust, and this Check It NOLA is still operational. The website is no longer operational. We're redoing it for the next step. So here are some of the advertisements we used. You could see that we were trying to demonstrate young men and just everyday things that they might be doing their laundry, playing basketball, just hanging out. We focus grouped a lot of them. This week, we put the kibosh on this one because, as you can imagine, the guys didn't like it, that it looked like a woman was telling them to go get tested. So they didn't like this marketing. So we definitely made sure that all of our marketing material was focus grouped, and we got input from our community advisory board. So we had a lot of partners. We started with the barbers, and then we moved to historically Black colleges and universities. We then moved to a community-based, a community college, and then many other spots. We had wing shops, we had car washes, just about anywhere that young men would go, we went there. And we were able to get about 50 partners. It was pretty stunning how many people were willing and excited about the program and really helped promote it for us. And by having these partners in the community, it really helped us to develop this really important trust. So they trusted us because they saw that we were being endorsed by people that they trusted. Also, to keep our partners, those 50 partners, engaged, we had newsletters, we had a holiday party where we gave prizes to people who helped us recruit the most people. So keeping them engaged was really important. As I mentioned, we had peer referral. So the men were asked to refer their friends. And so at first we just gave them cards, or we gave them condoms to give to their friends with study information on it. We got a little slap on the wrist because one of the HBCUs was a Catholic college, and they didn't know we were passing out condoms. So we had to, we got kicked out of that university, but we're hoping to get back in there. We just say we won't pass out any more condoms. But anyway, we were doing it just without giving the person an incentive. Later, we tried with $5 and we really were able to really increase the number. So now we're going to go to $20. And we using focus groups, we figured that 20 is motivational, but it's not coercive. Like they wouldn't coerce somebody to go on the study for $20. So we'll have to see if that happens. We're going to be tracking that and monitoring that very carefully. So how do you evaluate this program, which is really a seek, test, and treat community-based program? How do we evaluate that? Because one of the things that CDC cares about is, does it have any effect on the rates in women? So how do we evaluate this, knowing that the intervention was in men, but we want to determine that it had an impact on the rate in women? So we did it through a multimodal ways of going about evaluation. First, we did mathematical modeling. Then we monitored chlamydia rates using Medicaid data. Now, the reason we did that rather than using the Office of Public Health, which keeps surveillance data, they don't know who's tested negative. They only know who tested positive. So their rates are a little funky. They're not accurate because we don't know who wasn't tested. So they make that rate on top of the census, but that makes the assumption everybody's tested, which we know is not the case. Even for women that we are supposed to get tested, it's only about 45% of women of that age range that actually do get tested. So it's very subpar. So we did a lot of process evaluation as well. We did qualitative research. We monitored research at the uptake of the research, and then we grounded it in a salient health belief model. So here are the findings. So first of all, in our qualitative research, the information was coming out very resounding. They were worried about privacy. They wanted to make sure people didn't know. And they were also highly afraid of conflict. Like they kept saying, oh, well, I don't want the drama. I don't want the drama. I don't want to know about if I have chlamydia because I don't want to have to talk to my partner. There's also a lack of knowledge. Some people thought chlamydia was the same thing as HIV, and they're like, oh, I'm going to die. And so we had to explain to them, no, this is a very treatable infection. It's very common. It's easy to get rid of as long as you take the medicine. There's also fear of stigma. Like, are people going to now not respect me because I have this infection? There's also fear of loss of confidentiality. And then many of them said, well, even if I'm found to be positive, how do I get the medicine? Because I don't have transportation. I can't get to one of your Walgreens. So when we found that out, then we decided to add in mailing the medicine to them. Some people like that. Some people didn't like that. But we also added, I think for all of these community-based things, options are the best thing. Allowing people to have as many choices as possible lets them to tailor how this intervention would work for them. So here's a little data. It's going to be, might be a little confusing for people that aren't really used to a lot of numbers. But in the original intervention, what we were doing is having anybody who got infected, had the Office of Public Health call them up and interview them to find out about their sex partners. And then the Office of Public Health would call the sex partners to get them treated. And that worked miserably, I must say. What happened is only about 17% of named partners actually got treated, which is really, really quite subpar. We did not think that was very good. So what we decided instead is to use expedited partner treatment, meaning we would give the medicine to this young man to give to their sexual partners, and then their sexual partners, when we did that, instead of having the Office of Public Health intervene, because people were afraid of the Office of Public Health. They didn't know if it was connected to the police station or whatever. They didn't know these people. They didn't know their phone number. Once we got it, it was our own staff giving them the medicine. We were able to more than double, almost triple the amount of partners that got treated. And actually the number of index men themselves, the men who tested, we actually got that up to about 85% from about 59%. So we want to get that up to 100%. There's no reason all of those men shouldn't get treated, but sometimes phones change, they move, they decide they don't want to take the medicine. So we can't probably ever get 100%, but we got it. We hope to get higher than 85% in the next round of Check It. Okay, so this is our mathematical, not our mathematical model, but our economist did the evaluation and looked at the Medicaid data. And as you can see, the dotted line is our control areas, and the solid line is the intervention area. So you can see that what we did was we selected certain parishes throughout the state that had similar demographics to New Orleans, and we actually weighted them to make sure that they were similar. And you can see they were very similar. The rates were very similar until we get to 2016, when we started to do the intervention. And the intervention wasn't like all of a sudden, it was ongoing. So you can see that there was a widening, and in the intervention site, the rates in women went down. It kept going down, whereas the rates in the control sites went down a little bit, but then rebounded back up. So we were able to check, it was able to reduce rates in women by about 2.44 percentile points, which might not seem like a lot, but in the context of public health, that's a big intervention. That's a big impact. So we declared this a success, that we were able to reduce the rate of infection in women by testing men. This is the mathematical modelers, and what they did was they made this Google New Orleans. So they did, through, I don't know if it was an artificial intelligence or what, but they crafted sort of an experimental mathematical model, and they would put in different scenarios. So with the one scenario we asked them to check is, what if we screen men? How would that affect the rates in both men and women? And you can see in men, when we started screening men, this is when we first started the intervention, and it went down and it stayed down until we stopped the intervention. There was about another year of that it still worked, but then it went back up. So in women, we were screening only men, and in women, theirs also went down. And when we stopped the intervention, it eventually rebounded. So this told us that this intervention, no matter what it is, it has to be ongoing. It's not a one and done deal. But what we find is that for every 5 men screened, we averted 1 case of chlamydia in women. So every 5 guys screened, you're going to reduce 1 rate in women. That means potentially one less baby will have infection. And so this is all important. So we also, Dr. Stecker also did a cost analysis. And so we really, because if you do an intervention, and you might be saying to yourself, well, this is a really big intervention. How could anybody ever reproduce this anyplace else? Well, I think it's worth their while to think about it, because we did the assessment and we found that here's the control, here's check it. And the medical cost of the intervention was it was a little bit less in check it, and it's cost savings. The program costs were higher, so there's no program costs. But if you subtract the program cost, you can see that it's pretty minimal for the amount of quality adjusted life years. So QALYs, if you have anything less than 50,000, it's a good program. This was only 6,000, so it means we spent 6,000 to improve a quality adjusted life year for people. So this was it's cost effective, modestly, but most importantly, it really improved the quality of life of people. And then we did mathematical modeling. Dr. Mac Hyman and his colleagues did mathematical modeling so that you could see for every 10% of the population you screen, what percentage rate could you reduce in women? So if we had got 30% of young men, young African-American men in New Orleans screened, we would be able to reduce the rate from what we knew it to be at about 12.5 to 9.45, which is almost exactly what we found. So again, it corroborates what we said. So for every 5 men screened, 1 case is prevented in women. For every 16 men screened, 1 case is prevented in men. So it's more efficient actually as an impact on women. One thing we noted is that we had only been screening in the genital tract, and now we know that there are lots and lots of infections in the extragenital tract, like the mouth and the anus. And so we wanted to know, would we be missing infection if we only tested in the genital tract? And these data demonstrate a lot of people are engaging in oral sex as well. The majority of people are engaging in oral sex. There's only about 42 that are only doing vaginal sex, about 7% or 5% have no sex at all, but the majority were engaging in oral sex. So in the next iteration, we're going to do a pharyngeal swab to see about oral infections with chlamydia, because you can have an oral infection. If you only engage in oral sex, you can have an oral infection, but no genital infection. So we're going to test that as well. And this is more data that shows that we really do need to consider oral sex into this factor this into the equation, because if you look at people who said they always use condoms compared to people that said they never used condoms, if they only engaged in vaginal sex and they always used condoms, they had a somewhat lower rate of infection of chlamydia. But if those who engaged in vaginal and oral sex, that was flipped. So we could see that said they were always using condoms, but they had a much higher rate because they're using condoms for vaginal sex, but they're not using it for oral sex. So we did find that very few people actually there are condoms for oral sex. They don't have the chemical on it, but not very many people use them. And so a lot of people said, a lot of the reviewers said, oh, well, you're going into historically Black colleges and universities. Those folks aren't at risk. And to them, I say, haha, yes, they are. Unfortunately, we had some of our highest rates were in our HBCUs. And it makes kind of sense because they're just stepping out of their family of origin and moving off to become an adult. So they're maybe trying out new things and they get infected. And so we do see that there are a lot of people, and about a third of our folks had multiple sexual partners. So anytime you have an additional sexual partner, the probability alone that you will get an infection is higher. So we did see that we were indeed getting at very high risk people or high prevalence people. So that was 6 years of our life, which was really fun. We had very creative, wonderful people working on this study. They were constantly keeping it real for me because what do I know? I'm an older white woman, and they would be able to tell me what needed to be done for this population. So it's really important that you talk to the population to understand. So in this next iteration, because we found that a miserable only 45% of those women were getting screened, women were mad. They're like, why are you screening the men and you won't screen us? And we kind of lost our reason for not doing that. So we're going to add women in. We're also going to, because of our data was showing a strong signaling that oral sex is factoring into the equation of these chlamydial infections, we are also going to test for extragenital infections. We were going to test for anal infections as well, but pretty much the focus groups are not liking that. And so I don't think we're going to be able to do that in a community-based event. I think you can get anal swabs in a clinic-based event, but not in a community. I think they can do oral swabs. After COVID, people are they're more used to nasal, but sometimes people do oral swabs for the flu or for COVID. So we think that they can do them. Unfortunately, what happened is they did find out that azithromycin has become, in some areas, resistant, that the chlamydia has become resistant to azithromycin. So they are recommending the first line is doxycycline, but in this area, we don't have that issue. And because most of the people are asymptomatic, probably the azithromycin, our providers have corroborated, and they say that azithromycin is just fine and cefixime is just fine for gonorrhea. But we are going to rescreen the people after they get the medication. We're going to wait for 3 months and then rescreen them to make sure that they didn't get the infection again. We're also, because we asked the participants, have you ever been told you had HIV or syphilis? And we found a very high rate of this. So because of that, we're also going to add an HIV and syphilis testing. In our original study, we didn't add in HIV and syphilis because it added a level of complexity. You have to get a finger prick, you have to get a capillary blood stick. So that is a little bit, would have kind of made it a little more complicated. And also we didn't know if that would serve as a barrier, like people would be afraid to get HIV tested. They might be okay with getting chlamydia tested. But through focus groups and through talking to the participants, they really want HIV and syphilis testing. We're at Louisiana, New Orleans specifically, and actually the whole country and the whole world is having an outbreak of syphilis right now. And we need to get that under control. So we're going to add in HIV and syphilis, and we're going to see if they can do that capillary blood stick on their own. We're also going to expand it. We were doing all of this interviewing and testing face-to-face. We're also going to allow them to just sign up, and then we do a televisit. So we mail the kit to them. We coach them on how to do it. They can mail the kit off at no charge to them, and then we can tell them their results and get them set up for medication. So we're hoping that, like I said before, options are so important. So maybe some people will want to do it face-to-face. Somebody will want to do it home visit. So we're going to allow that option. And as I mentioned before, we're going to refine our peer referral. We're going to give each person who is enrolled in the study or any of our partners electronic cards that will have their number on it. So if a person comes in the study and they have that electronic card, they will get credit for referring that person, and then they'll get $20 recharged on their gift card. So the ultimate goal is to, we've kind of morphed into, we answered the question, if you screen men, will it help women? Now we're answering the question, is this the way to remove health disparities for African Americans? There's no reason that African American youth should have a 7-fold higher rate of chlamydia other than just pure negligence, really. So if we can do this and it's acceptable to both sexes, then I think we'll have a much better try at curbing this epidemic of chlamydia that's going on in our country and worldwide, really. So I see that there might be some questions in the chat. So Dr. I'm gonna not say your name right, Emmanuel, from Ethiopia, and in our country, we still provide STI treatment based on clinical algorithm, not an etiologic test and treat. So that's called syndromic. It might be, is it syndromic? Or is that, I'm not sure if that's syndromic treatment or, so sometimes when people have certain symptoms in areas where they don't have good diagnostics, they will just treat them presumptively. And we do that for sex partners of people that have an STI. We just treat them presumptively. Because, for example, in the case of chlamydia, about 30 to 60% of those partners have chlamydia. So you might as well just give them the medicine. It's cheaper and it's easier to just give them the medicine. And in things like trichomonas vaginalis, it's even higher. It's about 70%. So yeah, so some places don't have the diagnostics capability. They might do syndromic treatment. Heather Q asked, does circumcision status change the likelihood of transmission? Could the test ever be done alongside high school age required vaccines like meningitis? So 2 questions, really good ones. We do know that circumcision does reduce the chance of a lot of the STIs, including chlamydia. It's not a panacea, but because the foreskin helps hold in some of the epithelial cells that in the sebaceous gland cells, and it's a very nutrient-rich environment for chlamydia. So when you remove the foreskin, you do remove some risk for chlamydia, but it's not complete. And your second question, could it ever be offered along high school age folks requiring vaccines like meningitis? Sure, that would be at the will of the people that make the recommendations. I think it would be a great idea. And I think too few of our kids get meningitis vaccine too. So if any way we can get a more clever response or clever ways of getting at these youth to get them tested and treated without, judgment and without making them feel bad about it, that would be a good thing. Adrian Hens asked, was risk reduction, harm reduction, education a component of the study? Did you partner with a local health authority to enroll individuals who were hard to reach for treatment or experienced barriers to care? Yes, we did a lot of risk reduction education. Our staff was constantly counseling people. We had in our social media, we had a lot of like little excerpts on how to use a condom properly, how to negotiate a condom. We also had on our website, there was a lot of what we called web education. We had videos and all sorts of things. And as far as getting at hard to reach individuals, that was our whole goal. We didn't want to, we didn't go to clinics because people who are at clinics are already getting screened. We went into the nooks and crannies of the city where people don't go. And we went to NORD, New Orleans Recreational Department. We went to, any place we could find young men, that's where we went. And we found 1,905. We would have found more, but we got stopped because of the pandemic. So we might have sent more. And Dr. Emmanuel does talk about, he does say that syndromic treatment that they're doing in Ethiopia. And thank you, Heather. Thank you for attending the clinic. I just want to say one other thing about the study. I had so many collaborators. I just want to thank everybody, including our community advisory board, and our dozens and dozens of partners, our HBCUs, Walgreens themselves. We're now going to have another local pharmacy that's located in Central City, so we're going to add them on. I also want to thank NIH for providing the funds for this. And I also wanted to say this study spanned a couple of really important milestones in the world. COVID, COVID took two of our really wonderful partners, Miss Melanie, who worked at the community college, and she was helping us to recruit people. She sadly died of COVID. And then Shorty, who is one of our high volume recruiters, died of COVID. Then, of course, the Black Lives Matter issue came in the middle of this. We couldn't not address that. So a lot of our social media did address Black Lives Matter and no justice, no peace, and things like that. So, and we had so many successes and challenges. So I just wanted to say thank you so much for attending. And if anybody has any more questions, either you can put them in the chat, or I don't know if they can shout them out.
Yeah, so we have two more questions in the chat, Dr. Kissinger. And again, thank you so much for presenting today's Public Health Discovery Seminar Series. But we have one question that said, can you come again on the evaluation method of Saline Health Benefit Model?
Oh, the salient health benefit. So the salient health belief model, that was mostly Dr. Lisa Letter, who was interested very specifically in the expedited partner treatment. She wanted to know how people were going to give them the medicine, what were some of the barriers to it. So she grounded her qualitative research in that. We didn't end up using it too much, so I skipped over it a little bit because it ended up being a little bit it didn't really work out that well for our population. They didn't understand it so much. So, yeah.
The next question we had was, what was the average age of the male population?
Yeah, the average age was about 20. So the age range went from 15 to 26. We got a lot of 20-year-olds, mostly because we were really focusing on freshmen at the HBCUs. Those are the groups that tend to have really high rates because they're trying things out. We didn't get that many young kids, and we couldn't go in high schools. The state does not allow you to ask any sexual health questions. They wouldn't allow us to recruit in high schools, and we couldn't ask the questions. So we tried to get at those people by going around, like going to the recreational facilities or wherever else those people would go. But it would have been very efficient if we could have gone in school. They wouldn't allow us to do that, so we couldn't do that.
Next question we have is, I found your study very compelling. Thanks for presenting it, Dr. Kissinger. I was wondering, does the study include only asymptomatic participants, or are symptomatic individuals are also part of the sample? Additionally, if symptomatic participants are included, does the study facilitate testing for co-infections such as other STDs? Finally, do you have any thoughts or recommendations on how to improve access to reproductive health care for women diagnosed with chlamydia?
Thanks for all those great questions. So the first one I will say, we were looking mostly for asymptomatic. The symptomatics, I'm assuming, would go to clinic. We every once in a while did get a symptomatic, particularly during COVID time, because they couldn't get tested. So we did notice an uptick of symptomatic folks, but for the most part, most of our group, I think about 85% of them were asymptomatic. So we were really looking for the asymptomatic ones because symptomatic are likely to go in and get tested. So that answered that question, I hope. And then the next one. So this was also expedited partner treatment. And this whole thing is more to get people interested in their sexual health, to have them to demystify testing. And then we want to warmly pass them over to the clinics. So then we want to say, okay, this is what we're doing now, but you should start thinking about going on an annual basis to these clinics or your primary healthcare provider. So we had two clinics, Crescent Care, and then the Ruth Fertel Adolescent Health Clinic, and then the drop-in clinic, actually 3 clinics. So people could go there and they either do low cost or no cost, depending on the needs of the child. And so we were trying to just stimulate their interest, show them where they can go, into youth-friendly environments, and get themselves tested. So my recommendations on improving reproductive health care for women diagnosed with chlamydia, it's really, a lot of it is getting women to go into healthcare, first of all, and then it's also getting the providers to test them. So there's no reason why 45% of the women aren't getting, only 45% of the women got screened annually. All of them should be getting screened annually. They were all sexually active, so they should be getting screened. But sometimes providers don't ask the question, they're too busy, they get distracted by other illnesses, but really making it as easy as possible. Now, I'm going to Barcelona next week to present this to my European colleagues. People don't even have to go to the clinic. They just walk in, give a pee test. They don't have to sign in anything. They give them a number, their phone number, and then they get treated. We don't have socialized medicine here, so that might be a hard sell. But if we could move to some kind of hybrid model where at least for these vulnerable youth or youth that don't have access to care, that we could provide them with much easier testing. You know, one of our STD clinics is right next to a police station. That's not a good position for that place to be. It serves as a barrier for some people. I hope that answered your question.
All right. Is there any more questions? Please feel free to drop them in the Q&A chat.
Hey, well, thank you so much for your attendance. Thank you for your accolades that you've given me in the chat. We're really looking forward to the next iteration of this. We really are looking forward to reducing health disparities for young African-American people in the realm of sexual health. And so I look forward to telling you this in 5 years, what we found.
So we don't have any more questions. Again, thank you all so much for joining today's Public Health Discovery Seminar Series. Oh, this person is saying thank you for your presentation. Another person said this was a wonderful presentation, and they used
Thank
to be
you.
a disease event.
Oh, love DIS. It was DIS week, I think, last week. Yeah.
And so thank you all so much for joining today's Public Health Discovery Seminar Series. Thank you so much, Dr. Kissinger, for presenting today.
Thank you for inviting me.
And if we're going to give you back 9 minutes of your time. So again, thank you all so much. And you all have a wonderful Wednesday and a wonderful week, and take care. Bye.
Bye.